Pulsed field ablation has emerged as a revolutionary paradigm shift in the treatment of atrial fibrillation, transitioning with unprecedented speed from an experimental concept to a mainstream standard of care in electrophysiology labs worldwide. I am glad that the first one in my region has been performed right in my city. Unlike traditional thermal ablation modalities such as radiofrequency ablation and cryoablation, PFA relies on a non-thermal energy mechanism called irreversible electroporation. Pulsed field ablation utilizes ultra-short, microsecond or even nanosecond high voltage electrical fields to target cardiac tissue. These electrical pulses disrupt the lipid bilayer of cell membranes, creating permanent nanopores. This leads to a loss of cellular homeostasis, leaking of vital ions, and subsequent apoptosis or necrosis of the tissue. The primary clinical advantage of PFA is its high threshold selectivity. Cardiomyocytes have a significantly lower electrical field threshold for cell death compared to adjacent non-cardiac structures. This means the ablation can successfully isolate pulmonary veins while leaving vulnerable neighboring tissues unharmed. Traditional thermal therapies can cause collateral damage due to heat or cold dissipation. Pulsed field ablation addresses these critical limitations by offering unmatched safety profile. Because it preserves the extracellular matrix and selectively spares non-cardiac tissue, PFA drastically reduces or eliminates catastrophic complications like atrioesophageal fistulas, phrenic nerve paralysis, and pulmonary vein stenosis. Pulsed field ablation lesions are created in a fraction of a second compared to the tens of seconds required for a single thermal application. Landmark trials show that total pulmonary vein isolation time and left atrial dwell time are significantly reduced, optimizing laboratory workflows. Advanced multi-element or single-shot conformable lattice catheters allow operators to achieve rapid contiguous lesions with high acute success rates and excellent long-term durability upon remapping. Major global multicenter trials have solidified PFA's place in clinical guidelines. ADVENT trial, the definitive prospective randomized controlled trial demonstrating that pulsed field ablation is non-inferior to conventional thermal ablation, RF and cryo, regarding primary safety and efficacy endpoints in paroxysmal atrial fibrillation with a lower rate of redo ablations. Manifest 17K, a massive real-world post-market registry tracking over 17,000 patients, confirming excellent safety and reproducibility across diverse global centers. Sphere 360 trials evaluating newer all-in-one single-shot mapping and ablation lattice catheters showing a 1-year freedom from atrial arrhythmias of up to 88% with highly optimized pulse waveforms. While pulsed field ablation has revolutionized the field, widespread clinical implementation has revealed unique challenges that require careful management. Hemolysis and renal strain. The high voltage electrical fields cause mechanical destruction of red blood cells passing through the catheter array. Severe or excessive ablation can lead to high free plasma hemoglobin and myoglobin levels, which are nephrotoxic and have occasionally caused acute kidney injury requiring temporary dialysis. Post-procedural hydration protocols are frequently utilized to mitigate this risk. Microbubble formation and coronary spasm. Rapid electrical arcs can generate transient microbubbles in the bloodstream or induce localized temporary coronary artery vasospasms, particularly when ablating near the mitral annulus or tricuspid isthmus. Skeletal muscle activation. PFA requires general anesthesia or deep sedation because the high voltage pulses stimulate skeletal muscle contraction, requiring adequate neuromuscular blockade for patient safety and comfort. According to consensus surveys by European Heart Rhythm Association, pulsed field ablation has reshaped electrophysiology, capturing a dominant share of first-time pulmonary vein isolation procedures over the last few years. The field is currently transitioning into an integrated workflow area where single catheter designs combine high-density electroanatomical mapping with immediate pulsed field delivery, creating a highly customized, fast and safe approach to conquering atrial fibrillation. Short video clips of the procedure are available at the X handle of Dr. Arun Gopi.